Ma'am, we are live.
Hello, am I audible?
Yes, ma'am.
So I'll be sharing my presentation. Is my presentation visible?
Yes, ma'am.
Good evening, one and all. I am Dr. Divya Subramaniam. I am a consultant ophthalmic surgeon practicing in Bangalore. I specialize in cataract surgeries, ocular surface disorders, and ophthalmic plastic surgery. Today, the topic of discussion is Sjögren's syndrome and the associated dry eye. As we all know, Sjögren syndrome is named after the Swedish ophthalmologist who in 1933 described a chronic inflammatory autoimmune disease which causes lymphocytic infiltration of exocrine glands, mainly the lacrimal and salivary glands, and therefore creates dry eyes and dry mouth in the patients. So we can uh, call Sjögren syndrome either as primary or secondary based on association with other autoimmune diseases like rheumatoid arthritis or SLE. Patients can also present with fatigue and migrating muscular and joint pains in primary Sjögren syndrome. Worldwide, the prevalence of Sjögren syndrome is 0.06% and 90% of which affects the women. It is a disease of insidious onset, and most of the times, due to this reason, there is delay in diagnosis of the same. So, the precise triggers leading to autoimmune acinar damage are not known in full, but risk factors include genetic profile of the patient, androgen status, and exposure to environmental agents, ranging from viral infections affecting the lacrimal gland or to polluted environments. And nutritional deficiency in omega 3 and other unsaturated fatty acids has also been reported in patients with Sjögren syndrome. Mainly, the diagnosis of Sjögren syndrome is by its clinical signs and symptoms, along with support of our diagnostics. There are several classification criteria from many years now. The most common are the American Association or the European Association or the consensus between them or the Asian criterias. But most popular one is the one by American College of Rheumatology in consensus with European League Against Rheumatism classification criteria, which came out in 2016, wherein the five criteria they take in are the lip biopsy of minor salivary glands, which gets 3 points, a positive test, and the second is serological evaluation of autoantibodies associated with Sjögren syndrome, which gets 3 points if they are positive. And third is being the ocular surface staining, wherein we follow a method where if the surface shows staining and it is graded, more than 4 or 5 score is given 1 point. The fourth criteria, Shermer's test, which we perform on the patient to test the volume of tear flow. Fifth criteria is the unstimulated salivary flow, which is less than zero point 0.1 ml per minute is given 1 score. So, coming to dry eyes per se, among the ocular manifestations of primary Sjögren syndrome, dry eye remains the most common, along with ocular surface damage like sterile corneal melts, perforations, infiltrations, ulcers related to the dry eye itself. But these patients can also manifest with episcleritis, scleritis, uveitis, optic neuropathy, retinal vasculitis, cicatrizing conjunctivitis, though not as common as the dry eye. So, briefly about the tear film, we all know it is a trilaminar layer with the outermost layer being the lipid layer, the middle layer being the aqueous layer, and the maximum part of it is aqueous. The innermost layer is the mucus layer produced by the goblet cells. The aqueous is produced by the lacrimal gland, and lipid layer is produced by the meibomian glands. So, dry eyes is recognized as a disturbance of the lacrimal functional unit, an integrated system comprising the lacrimal glands, ocular surface, and lids, and the sensory and motor nerves that connect them. So, it's a multi structural damage that leads to dry eyes in these patients. So this picture describes the various forms of dry eyes that we see in our routine practice. But today we are limiting our talk to the one caused by the inflammation in Sjogren's disease. uh, mainly to the lacrimal gland. So dry eye are of two types when we evaluate. The first one is the aqueous deficient type. The second is the evaporative dry eye type. The most common we see in our practice is the evaporative dry eye type. But there are patients who present to us once in a while with aqueous deficient type, and in that we divide them into Sjögren syndrome, dry eye, particular when we find the other positive signs in them, or the non-Sjögren's dry eye, which could be a primary lacrimal deficiency or other things. So, in you should know in Sjögren's syndrome, it is the aqueous tear deficient dry eye. So, all short form of it is ADDE. So, it's an exo. To again remind ourselves, it's an exocrinopathy in which the lacrimal and salivary glands are targeted by an autoimmune process. The lacrimal and salivary glands are infiltrated by activated T cells, which cause acinar and ductular cell death and hyposecretion of tears or saliva. The inflammatory activation within the glands leads to the expression of autoantigens at the surface of epithelial cells. So there are two types. The primary Sjogren's is associated with ADDE in combination with symptoms of dry mouth. The secondary has the features of other overt autoimmune connective tissue disorders like rheumatoid arthritis, SLE, etc. So non-Sjogren syndrome dry eye, the primary type is could be due to age-related dry eye, congenital alacrimia, familial dysautonomia. Secondary type could be due to lacrimal gland infiltration, malignant infiltration, sarcoidosis, lymphoma, AIDS, lacrimal gland ablation, lacrimal gland denervation. Or it could also be due to obstruction of lacrimal gland ducts due to trachoma, secretory shelf emphigoid, and mucous membrane emphigoid, erythema multiforme, chemical and thermal burns. Why do we need to know this structure? They're similar in presentation in the initial phases. So it could also be due to sensory block or a motor block. So evaporative dry eyes mostly are due to intrinsic causes like MGD, Meibomian gland dysfunction, most common type found nowadays, disorders of lid aperture, low blink rate, uh, the extrinsic causes being ocular surface diseases like vitamin A deficiency, topical drugs and preservatives, and allergic conjunctivitis. So dry eye severity we can grade using any of these grading schemes as 1, 2, 3, 4, depending on patient symptoms and the signs that we see on the conjunctiva, cornea, the lid, and with our objective tests like tear breakup time and Shermer score. So evaluation, coming to evaluation of tear film, first and foremost, as soon as the patient sits on a slit lamp examination, we should, without disturbing them, check for the tear meniscosite. Whether by flashing light on them or by some other method, we may disturb the patient's reflex basal secretions. So do not elicit a reflex in them through other stimuli. So the tear meniscosite is the first thing that we have to notice. Anything less than 0.3 millimeter is abnormal. We can also stain the surface to highlight the tear film as shown in this second picture here. So tear breakup time is the second thing you note when you ask the patient to blink once and open the eyelid and not to close it again. You can see there are several breaks in the tear film as shown in the stained picture. We can also see them clearly without staining also by practice. Once should practice in each and every patient, you can make out this tear breakup time. So a normal thing is more than 10 seconds. Borderline dry eyes could be 5 to 10 seconds. Abnormal is less than 5 seconds. So if you see a dark spot like this, within 5 seconds, it indicates the patient's tear stability is not good. So coming to our most favorite test we do with our dry eye patient, Shermer's test. So shamas may is very easy, very friendly to do to the patient and inexpensive. But then we have to remember it has a lot of observer variations. The person doing it also matters, and how gently you do the test is important. So Shermer test is we use a Wattman 44 blotting paper, which has scale over it in millimeters. So we fold one end of it and insert into the lateral one-third lower lid margin into the conjunctival cul-de-sacs without disturbing the patient's surface too much. So otherwise it elicits lot of tearing, which could have false positive or false negative sign. So once inserted, we wait for 5 minutes or 3 to 5 minutes and look at the wetting of the paper. So inference at 5 minutes is more than 15 millimeter is normal. 5 to 10 millimeter is borderline dry. Less than 5 millimeter is very, very accurate in telling that the patient has dry eye. So hypersecretion due to reflex stimuli could give wrong indications of a dry eye patient, but definitely a dry paper is pathognomic of the disease. So the third thing we do when the patient is sent for dry eye assessment is definitely we may not do this in every patient we suspect dry eye, but when sent for a dry eye evaluation, fluorescein staining is one of the easiest stain we can use and it's very liberally available. Rose Bengal stain is nowadays not so frequently done. It's very stingy also to the patient and lissamine green can be used instead of rose bengal. We use a scoring system called van Westerveld scoring system where the ocular surface is divided into three zones: the nasal bulbar conjunctiva, the cornea per se, and temporal bulbar conjunctiva. Each zone is given a score of 0 to 3, and if the score of 3.5 or more is there, you definitely can diagnose it as a case of keratoconjunctivitis sicca. So there are newer technologies, many are available in the market now, but most of them are very expensive and reserved for research purposes like mebometry, mammography, brush cytology technique, flow cytometry and impression cytology. The latest one, what they describe is a tear ferning test, where they dry up the tear and put it under the microscope and examine for the ferning patterns. The fluorophotometry, and another tear function index, where it is the quotient of the Shermer test value and the tear clearance rate. A tear, the function index of less than 40 is 100% sensitive for patients with Sjögren syndrome dry eye. So, in conclusion, instead of confusing us with all the so many tests available, it is said that a combination of ocular surface disease index, which is a questionnaire, you ask the patient his daily activities, daily disturbances, his discomfort level in a questionnaire. We can take one of the standard questionnaires available online, tear breakup time, and corneal fluorescence staining. These three things, if combined properly and assessed properly, is considered the best approach to distinguish Sjögren syndrome dry eye from other causes of dry eye. So coming to the management of the same, so we have various levels of management actually. Initially, when patient presents with mild to moderate dry eyes, lubricants alone will suffice. Lubricants are available as eye drops, as gels, as ointments. So then the next level treatment, we concentrate on tear retention. Whatever is available for the patient, we should avoid the drainage of the same. The tear stimulation is not as popular as the first two. There we can also use biological tear substitutes. Then the anti-inflammatory therapy is the mainstay of therapy whenever inflammation is associated with the condition. Then the patient can be supplemented with essential fatty acid oral supplements and also asked to follow some environmental strategies. And final stages where the ocular surface is too damaged, we need to go in for some surgeries. So tear supplementation, as told, we need an ideal lubricant for the patient, which should have electrolytes in them, potassium bicarbonate mostly, a good osmolarity and viscosity of the product. It should stay on the ocular surface for long. It should have an increased duration of action and penetration of the drug should be good. It should be mostly preservative free. Since most of these drops can be toxic to the already damaged ocular surface. Eye drops, ointments, gels, most of the time we prescribe hydroxypropyl methyl cellulose, shortly called HPMC, or CMC, carboxymethyl cellulose, polyvinyl alcohols, or hyaluronic acid, and other polyols. Tear retention, we mostly use something called the punctal plugs, where the patient is very symptomatic of dry eyes and has a Shermer test positive at 5 minutes, and he shows also ocular surface dye staining. So the plugs are of various variety, absorbable and non-absorbable are available, and these are not at the sometimes misuse of these punctal plugs are also seen, because these are not good for every patient we see with dry eye. The patient could be allergic to these plugs. They can cause punctal ectropion. They could have pre-existing lacrimal duct obstruction. It could lead to infections in the patient. So complications are plenty with these also. We should be very shrewd in using these punctal plugs. So tear irritation can we can also advise some moisture chamber spectacles and scleral contact lenses for patient with severe ocular surface discomfort. So tear stimulation, not very popular. I'm not going to go deep into this. So coming to biological tear substitutes, yes, there is a role for autologous serum. It helps in the regeneration of the ocular surface to a certain extent, but then we cannot trust the patients with judicious use of these drugs prepared, and they're short-lived. So it needs to be prepared again and again. So there are cases where we need to end stage diseases when we encounter, we may need to plan for a minor salivary gland or a major salivary gland auto transplantation in these patients. A very badly conjunctivalized surface. The patient presents with persistent severe pain despite all the other treatment therapies they are going through. So the most common mainstay of topical treatment along with lubricants is our anti-inflammatory therapy, which includes cyclosporin and tacrolimus, which is off-label prescription we give, and it is much more powerful than cyclosporin. In my practice, at least, I have switched over to tacrolimus ointments more than the cyclosporin. And corticosteroids, very, very judicious use has to be done, because surface is already compromised. It may lead to other conditions like corticosteroid associated glaucoma and cataract, both potentially leading to blindness of disease, because if patient develop cataract in these conditions, we are unable to operate them for a long period of time due to the unstable ocular surface. So we usually use the low potency loteprednolol or fluoromethanol. Not, we don't use prednisolone or dexamethasone at the start itself. And ointments also, steroid ointments have to be really, really avoided in these patients. Liftegrast eye drops is the latest in the armamentarium of anti-inflammatory therapy. It is yet to be tested in Indian population. Just now we are hearing about this here. So we'll be in few years we'll get to know whether it's really effective. So tetracycline, oral doxycycline works wonder if there is associated mebumin gland dysfunction. It helps in resolving the thick secretions associated with it. So this is the mainstay of topical treatment. Coming to supplementary treatment, essential fatty acids, multivitamins, omega-3 fatty acids can all be prescribed to the patient depending on the level they present us with. We also can ask them to avoid extreme and harsh environmental conditions, use a protective glass all the time. So emergencies are in this condition: corneal melts, sterile corneal melts, perforations where we have to resort to torsorrhaphy or a glue or suturing, depending on our expertise and the where the patient presents us, whether primary, tertiary, or a clinic level of presentation. We must be able to guide the patient to save the ocular surface at an emergencies basis. So surface reconstruction can involve amniotic membrane grafting, mucous membrane grafting, and stem cell grafting. In extreme cases where we cannot do much for the ocular surface, we resort to keratoprosthetic implants, and many a time patient gets some good vision to viable life. Treatment recommendation, as I told, it depends on the level of the dry eyes. Level 1, education and environmental and dietary changes we do. Elimination of the offending systemic medication if it is secondary due to them. Artificial tear substitutes, gels, ointments, and eyelid therapy if needed for MGD. Level 2 is anti-inflammatories, tetracycline, punctal plugs, secretagogues, moisture chamber spectacles. Level 3, serum, contact lenses, permanent punctal occlusion. Level 4 is systemic anti-inflammatory agents. Surgery is whenever needed. So coming to my end of my talk, most important, whether we diagnose dry eyes or treat dry eyes or guide them properly, When in doubt about the cause of dry eyes in an otherwise asymptomatic patient, timely referral to rheumatologist for complete evaluation to rule out or diagnose life-changing or life-threatening conditions like Sjögren's at the earliest is a must. So whenever the patient keeps returning back with dry eyes, that patient is not happy with the drops we have prescribed, it should ring a bell in us. Something more may be there in this patient. So ophthalmologist should not hesitate to refer to a rheumatologist for evaluation, even if it comes negative. So, but on a note, not all dry eyes are Sjogren's, and not all Sjogren's present with symptomatic dry eyes. So, evaluation of dry eye should include and be part of rheumatological evaluation as well as baseline assessment in moderate and persistent diseases. Thank you. Thank you so much for this opportunity.
Thank you.